Welcome to the Airway and PFC. We're slowly going through the CPGs using the March algorithm. My name is Aebhric OKelly. I'm a critical care paramedic. And Bill, you can introduce yourself.
Hello, Bill Vasios. I'm a PA by trade with a soft medic and operational background, a current doctoral student and simulation fellow.
Good. So for the next hour, we'll talk a bit about different airway options. So let's talk about Airway. Basically what I did is I went through 96 CPGs that are on the JTS website, and I broke them down into March pause L basically, and then the last bit is Hitman. So and I've made a spreadsheet with all of the CPGs that had the applicable CPGs, like there isn't one for splinting at all for some reason. And then all the way down through Hitman, which is prolonged field care, a bit of surgical, and a bit of other that didn't really fit into anything at all. But there's a QR code if you want to download that spreadsheet that I made. And in that spreadsheet, you can use it after the lecture or have it close to hand if you like. But in that spreadsheet is a link. So you just click and it automatically goes to the JTS page. And I found that pretty helpful. So as we walk through the March algorithm, or at the college we do CABCD all the way up to H as our patient assessment. We've talked about massive hemorrhage last month, and this month we'll talk about airway. Next month we'll talk about respiration. But today let's do a deep dive. I'm going off of the TCCC guidelines and using this skill set by responder level on airway. So ASM means all service members. It's a 6-hour course. Combat Lifesaver is a 5-day course. Combat Medic is a 63-hour course, generally for people who are EMTs, or 68 whiskeys. And then CP means combat paramedic. So let's take a look at this. These are what the TCCC guidelines are suggesting the skills that we have as combat paramedics. Bill, do you have any? What do you think about this list? Is it comprehensive? Is there something that you would add as a ALS provider?
No, for military medics, for pre-hospital austere environments, this is pretty comprehensive.
So they added a couple of things. They added head tilt chin lift, but they also added ETCO2. Why did they do that? Why is that an airway thing?
I think a lot of medics, military-wise, were having difficulty obtaining end-tidal CO2s, or EMAs. And a lot of the pushback from logistic and commanders and bean counters was that, well, you don't have a requirement for this. It's not something you're required to do per the CPGs. And so the folks that were writing the CPGs said, all right, this is necessary. And they state out the reasons why it's necessary. But mainly, one of the additional reasons they put it in the CPG was to add a justification for medics out there that are having difficulty obtaining it, saying, look, if you're expecting me to practice to the clinical practice guidelines, this equipment is part of those guidelines. And so we need to purchase those. We need to acquire them. And this gives them further justification if those people were having difficulty justifying spending the money for an end-tidal CO2 device.
I think with as cheap as they are and easily available, the EMAs is definitely one that doesn't take that much weight at all. And you can plug that right into an MPA and get your waveform. There's no reason whatsoever not to have an ETCO2. The other stuff isn't really cutting edge. We've had this list for a while, and I like to look at it. So it's kind of hodgepodge, and I'm a knuckle dragger, and I kind of like things in a clear and concise way. So I created a airway ladder, and this is what we use at the college to start at the very bottom of your ladder, and you slowly work up until you find something that works. And Bill, you you had some comments on the OPA. So as we go further up and they get the adjuncts get more and more invasive, the line crossing into what you can use in an unresponsive patient isn't always as it seems.
I think the NPA gets a bad rap because of maybe lack of training or lack of emphasis on proper sizing, proper positioning, the need, the justification, and verification that it's effective. I think all of those things are reasons why NPA gets kind of a bad rap. The OPA is something that is, as states later in the slide deck, it says that it's not tolerated. I would modify that to say that it's rarely tolerated. But I think if I'm going to stick my fingers in a patient's mouth for any reason whatsoever, I need to protect my fingers. And the OPA, if it does nothing else, it can be a bite block to prevent the patient from reflexively clamping down on your digit as you're trying to clear an obstruction or move the tongue or any reason why you would put your fingers in the patient's mouth. It's going to protect you to some extent. I think supraglottic is another thing that it states in the CPG that it's not tolerated. I would modify that. I wish they would have modified that to say that it's rarely tolerated, mainly because if your patient can tolerate an OPA and an supraglottic, neurologically, they're not doing well. But there are people walking around among us in the population that can tolerate, something like that because they have, a diminished gag reflex. But in medicine, if your patient is in trauma or just that sedated or that degraded that they can tolerate an OPA and a supraglottic, then it's generally not a good neurological sign for them, generally.
Well, in ICUs, there's a push now to get patients ambulatory. So they're intubated for weeks, and they're trying to get them up, awake enough where they're walking with a vent. I mean, so is it possible to medically make someone relax enough to be able to use some of these invasive airways?
Mm-hmm. Yeah, I agree.
Well, is a medically assisted airway device that there was a discussion on that. Maybe not all the way up to intubation, but having an eye gel in and midazolam enough to make him tolerate it. Is there some problems with that?
Yeah, I don't have much experience doing stuff like that. I don't want to speak beyond my capabilities.
Yeah, fair enough. Any questions so far, guys? You can type them up and we'll read them out. But this airway ladder, this is page 90 of our field guide, and we found that this is a pretty good reminder to have to hand when you 3 a.m, raining sideways, you're out on your knees in the street somewhere, and to refer to this. So moving on through the CPG. So here, working off of the concept we had with the skill level on what are the things that we have as combat paramedics, which is everything. This is from the CPG on the pros and cons of each of these. So head tilt, chin lifts. The pros, it's easy to do. Anyone can do it. The problems are how long can you do a jaw thrust with your hands and keep that airway open. You need to convert quickly into some airway adjunct. Recovery position is definitely an easy option. The sit up and lean forward. So we've always been taught to have everyone lay down, but what happens if they have a compromised airway of excessive bleeding, emesis? Having them lean forward and maintain their own airway is better than putting them back and laying on the ground.
I definitely think you should get your patient's input. Basically, if they're awake enough or aware enough and that they need to position themselves, they will do so. They will find a way to be in position, whether they tent, whether they, however they body position, they'll lean forward for drooling. I mean, they're gonna find a way without your intent. They're gonna find a way for them to breathe as comfortably as possible. And when they can't, that's when you need to consider sedating them and then, doing your algorithmic process of securing a definitive airway.
Yeah, they will be quite combative if you try to lay them down and all that blood is rushing to the back of the throat.
Yeah.
Good. So NPAs, OPAs are easy enough. NPA, there's risk of nosebleeds. Notice that there's nothing stating there's risk of going through the cribriform plate into the brain. So that is long since gone. You can put an NPA into somebody with a basal skull fracture. Oropharyngeal is not tolerated in most conscious patients. Bill Metz stated that some can, and same with supraglottic. And then the problems with intubation. We all like to intubate because it makes our job easier, but now you've got drugs you got to think about. How long can you keep them down? You now have an extra bit of we have an unresponsive patient now because I had to knock him down to be able to take his airway. Any other major cons?
Well, I think everything that you're doing when you're assessing the needs, the airway needs for your patient, none of them are going to be free. So if you do not need, if you're bagging them, if you position them properly and you're BVM and you have a response to their oxygen saturation levels and they're improving and they're somewhere between 90 and 96, which is your target window when you're oxygenating a patient. If you're getting them there with doing your BVM, well, then that's the right thing to do. You do not need to go beyond that in case, unless you get to the criteria where they talk about where you really should take a surgical airway, like burns greater than 40% or, loss of airway, all those things that we'll cover kind of later in the CPG. Nothing is free. You're going to pay a cost for it. The cost for you doing a BVM and positioning is that you tie up a person to do this. You may end up tying up two people if one person is not able to secure the C&E and maintain an open airway and bag at the same time. You might need to go two people where one person is holding the bag in position, in proper positioning and maintaining a good seal, and somebody else is actually squeezing the bag at the appropriate rate and volume. There's a cost for everything. If you can't spare one or two people to do a BVM because they can't do anything else, well, then you need to expend whatever equity that you have to maintain a surgical or take a surgical airway or do a rapid sequence intubation and secure the airway that way. But that is not free as well because it requires meds. It requires further additional monitoring. It's all your mismade products that you're going to have to do to make sure that the procedure goes well. There's quite a bit going on. So there's never a question of right or wrong. There's just you doing what needs to be done. And then there is a cost associated with that for time, equipment, and personnel that you just need to, nothing is a straight one-to-one exchange. There's going to be a cost that you're going to have to calculate as the provider based on your situation. And that's just too broad to cover in one single lecture. But if you have an example or a situation that you'd like to talk about, that's something that would be very helpful, I think, for the group if you have specific questions.
The amount of equipment needed to keep an intubated patient down, and you're burning through a lot of your stuff. And
you can. I mean, there's a way to manage that better than others, but once again, it's a cost that you need to consider when you're deciding, can I manage this patient and sufficiently oxygenate them with a BVM, or do I need to take an advanced airway? Right? That's just you're making those decisions on the fly in the situation at the time. And I think part of your planning, you need to go with what's the most likely thing that my patient is going to have to deal with, and what is the most dangerous or most complicated. You need to calculate those two extremes when you're preparing for a mission. What are you most likely to come across, and what kind of airways you're most likely to have to maintain, and what's the worst possible airway that you would have to maintain, and how do you prepare for both of those? And the transition between the two.
We also need to think about capability. As a critical care paramedic, I've done plenty of RSIs, but I haven't done one in ages. Would I be safe to do? I don't think I would. If I had somebody crash right in front of me, I had all my kit, Would I be comparable to do that? I don't think so. So the skill fade is tremendous on that particular skill.
Skill degradation is an entire podcast on its own. That's something that we should have a separate discussion about for skill degradation for everything across the board. Maybe we can do that after the March, we get through March. But I digress. If you need to figure out exactly how you're going to maintain and how you're going to plan, that's I kind of lost my train of thought there when I went off on skill degradation, because that is a gigantic topic. I squirreled myself.
So it's just a matter of I've done tons of innovations. Would I feel comfortable doing it now? And
Right.
then what's the minimum level? Or how many should a 68 whiskey or an operational medic be doing to feel comfortable enough to pull that trigger instead of jumping to the nuclear option and do a surgical airway?
Well, thank you for bringing me back. So you're trying to compare rapid sequence intubation, which involves a lot of drugs, which you have to maintain currency on and familiarization with, and correct dosage, and based on weight and size and all of that, versus a surgical airway. So the reason why they recommended the surgical airway, the surgical crike in the combat medic and the pre-hospital austere environment, is because although it requires sufficient training, that you're able to have a higher than 50-50 success rate, it requires less individual components to training to be more proficient. Whereas all you need to do is be able to do some immediate sedation, which you can do with ketamine, which you should have with everything else in TC3. You have to do a little bit of anxiety medicine that you can give a little bit of that. And then you have to do one procedure, which is the surgical opening of the airway and then putting the tube in. Those are 5 things roughly. But if you're going to do rapid sequence intubation, you have to learn how to use a laryngoscope. You need to have the strength to lift the jaw. You need to position. You need to give medications. You need to know how long to wait before those medications are effective so that you actually not fighting, still fighting the patient. Have you given them the paralytic? All of those components. So when you line up the tasks involved of doing a rapid sequence intubation versus a surgical crike, the surgical crike has a shorter list. And so to maintain proficiency, or to get to skill proficiency, to skill mastery, so you can forego some of the skill degradation because you don't do it very often. These things are called halo events. So high acuity, low occurrence. They're very intense. They're very emergent, but you don't do them very often. So you need to be able to practice. And I was going to tell you, Aebhric, that I was going to bring in the mental rehearsal at the appropriate time. This is it right here. So you don't do rapid sequence intubation very often, but if you've been trained in it, you could mentally prepare and rehearse that event. Just close your eyes and go through the process. What am I going to do? I'm going to draw up my medicines. I'm going to make sure I have a line. I'm going to go ahead and give those medicines. You're going to mentally rehearse what you do in sequence to the point where you can visually see it and rehearse it. You can do this on the plane when you're flying somewhere. You can do this while you're sitting in your team room. You can sit, have a lecture in front of you, go through it, and then close your eyes and sit and mentally rehearse what you just learned. So that when you close your eyes and you're like, oh shit, what do I do next? It kind of pops into your head because you've mentally rehearsed it to the point where you do have skill mastery. That's an entire separate, discussion about how to do something like that, whether it's self-paced, self-directed learning, in addition to having a subject matter expert talk you through the process to make sure that whatever you're mentally rehearsing is appropriate. So,
and that could work for any skill, any medical skill, or any
absolutely
tactical, operational skill, driving, everything. And that'd be a good way to hone your skills if you're not doing them consistently.
Yeah.
So
Yeah.
I need to be mentally going through an RSI because I haven't done one for a while.
Well, I would go back and rehearse the steps so that whatever you're mentally rehearsing is appropriate.
That's the challenge, isn't it? If you're doing all your training by yourself, you're always right. So you need to refer to make sure that you're not.
It sounds so intelligent inside my head, and then I speak, and then I'm wondering who that idiot is. So yeah, absolutely.
Yeah. I say that about when teaching ultrasound. Yeah, if you're not confirming what you're seeing to anyone else, you're 100% right. So let's talk about the nuclear option. So we talked about doing a intubation and let's say it just doesn't work. Now we have the nuclear option. So this is a higher success rate for people than for all levels who are been trained to do this. And I probably should have gotten a couple of those studies to reference here, that surgical airway is an easier skill to maintain than even intubating dead people.
Well, there's still a significant number of failures doing surgical pre-hospital surgical crikes. So I think definitely practicing and rehearsing this and understanding exactly what you should see and feel when you're doing a surgical crike and how to confirm you're in the location, doing all of that mental preparation afterwards, I think is very important for that skill, because you do it so often in practice. You can grab the practice tubes and use the tape to cover, to do those very low cost simulated surgical airways, or you could go get, goat trikes or pig trikes and kind of go through the process to do it on more pseudo live tissue, and then actually carrying out into live tissue training where you're doing it with, sedated simulated patients. That's that you scale that off. It gets very expensive if you're using the simulated patients, because you really only get one. You only get one good crike. The rest is, kind of sloppy thirds, fourths, 15ths, depends on how many medics you have training it. So that's a place where mental rehearsal could be beneficial when you have a large group, or just individually, just trying to make sure that you get to skill mastery.
So mismade, we're going to start talking about mismade. What's mismade?
A mismade is definitely something that you need to consider when you're doing considering an advanced airway. But I would expand this to any medical procedure. If you expand mismade mnemonic to preparation before doing any procedure, whether it's any minor surgical procedure, I think you can expand this to any other procedure, but it was designed in the original format for the advanced airway. So it encompasses making sure that your machine. So what are you looking at? When you're trying to take an airway, you should already have a BVM in place. Often in the simulation center that I'm working with, we'll run a simulated code, and the team leader will say, all right, I think, go ahead and you have airway, doctor or medic or nurse or PA or whoever the student is. You take airway, and they walk over to the patient with a laryngoscope in their left hand. And it's like, hold on, you're skipping too many steps. Like, there's so much more that you need to do before you get to the point where you're prepared to put a tube in a throat. So minimum is to have a BVM with a PEEP valve. Why is the PEEP valve important? The PEEP valve is important because once you maintain a good seal on your airway, you're holding the alveoli in a open position. And so most of the resistance when you're trying to insert air into a patient is because the initial opening of the alveoli, and it's that PEEP, if it's properly sealed in the airway, holds that airway open. And it's like if you're trying to blow up one of those balloons that make the fancy animals. When you try to blow up that long, skinny balloon, the most effort that you have to expend is the initial couple centimeters that you're putting air into that balloon. Well, that's the same concept of putting air into a patient's airway. You're trying to overcome that resistance. And that's if the airway is completely open. And so if you don't position your patient properly, you have to overcome that obstacle to getting air into the airway. And then when you get into the alveoli at the end of the trachea, you're trying to overcome that other obstacle. And that's where you're going to run into a lot of complications with your patient. Normally, airway is a negative pressure system. The patient drops the diaphragm, creating negative intrathoracic pressure, which draws air into the body. Well, you're doing the same pathway, but it's positive when you're doing it for the patient. If I'm breathing for myself, it's a negative airway system. If you're breathing for me, it's a positive airway system. And if it's a positive one, you can do too much. And so if you're trying to overcome that resistance and you bag a little too aggressively, you're going to cause more trauma, and this is going to snowball into a real problem. And you have a problem, but then it's going to get exponentially worse. So make sure that your machine or whatever equipment that you're going to have is organized, identified, and laid out properly. And the miss made here for machine is just talking, do you have it? You should have a BVM and a PEEP valve at a minimum. Better is if you have something like a portable ventilator or oxygen concentrator that you can use supplemental O2, and then, you know, best would be a full feature portable ventilator that you're trained on. Caveat, you need to be trained on it. Just don't have the cool one and you have no idea how to turn it on or make it go beep.
The PEEP is really important, and how I didn't quite understand it until I was like, okay, how am I going to know what a 5 PEEP is, what a 10 PEEP is? So I came up with a system of getting a big straw. I measured down the length of the straw, how many inches, because it's inches in mercury or inches in water, isn't it? And then I got a big thing of water, and I put my big straw 5 centimeters down, and I blew out of it. Okay, that's 5 PEEP. Then I put it down to 10 PEEP, blew, and then I could feel that resistance, and you get up to 20. And now so that's the only way I got it on why do we stop at 20? Because 20 was really difficult to get any air out of that straw. So I encourage you guys that are listening, try that. Try to get a biggest straw you can, measure out how many centimeters of water it is, and then you see the difference between 5 PEEP, 10 PEEP, 15 PEEP, 20 PEEP. That's, maybe I'm just a knuckle dragger, but that's the only thing that worked for me.
I would just modify that to simplify it. I would take a BVM and a PEEP and just put it on your face. Set the PEEP to 5 and just breathe. You should be able to expel the air just by relaxing and exhaling. And then crank it up to 10, maintain a good seal, and you might have a little bit more resistance just exhaling, normal exhaling. When you get to 15 or 20, you're going to actually have to force air out in a normal, otherwise healthy person when you got a proper seal and you have the proper PEEP set and you maintain that seal. In your training, when you're doing airway stuff, position, like work with another medic, have them put you in a proper position, the sniffing position, make sure that you get a good seal with your BVM and you're able to maintain a good seal. And if that person is able to get a good C and E, which we talk about a little bit later, if they're able to get a good seal on an airway, you should hear the PEEP valve when you're exhaling through it. And what will happen is, and how do you confirm that you have a good seal, is you should listen for that audible exhalation through the PEEP valve. Now, depending on how your hearing is in the environment, you may not be able to hear that. But if your patient is conscious or awake, or you're in this training, to make sure that you can do this properly, you'll actually feel, as the patient, you'll feel where the leaks are. And then you can tell, just use your fingers and point where the leaks are occurring. And then when you realize if your hands are too small or the gloves are too slippery and you're not able to maintain a seal in a completely benign classroom environment, then what are the odds that you're able to maintain a seal, one person with one hand in a stressful, real patient in front of you environment? So if you know that you can't do it in a calm classroom environment and you have to do BVM on a patient, just start with 2 people. Don't flounder in a real world trauma stressful situation when you couldn't even do it in a classroom environment. So just that's your patient that's the one that's not breathing in this time frame. So practice it enough to know your tendencies. Some people, their hands are just too small. They're not able to maintain a good seal on a patient. Sometimes the necks are too big, or the face and the facial hair and trauma. Just throw all that stuff in there. You're just know it. Part of escalating through that airway ladder that you identified earlier, Aebhric, is just knowing when it's appropriate to skip those steps, right? There's certain situation when you went up to a patient, I'm just going to go to a surgical crike because the patient has 30 to 40% burns, and I have the personnel to do the other things in March, and we need to do an airway, right? But other times you need to still prioritize it if you're the only medic. And really understanding your limitations is the first step in that.
Yeah, look at the Combat Lifesaver. They're given an MPA, an OPA, and a surgical crite kit. That makes their decision matrix quite simple.
Well, a simplified protocol isn't a bad thing, right? As long as there's a thought process that goes into simplification. It can't just be, oh, that's hard, let's not do it. Okay, why is it hard? You know, is it because we don't staff them? Is it because we don't equip them? Or is it we don't train them?
All right, that's the M in mismade. So moving on. Suction. So what are we looking at?
Just some way to remove secretions from the mouth, whether that's an improvised suction with a syringe and a tube, whatever it is. Those things are all horrible. Some people have had good luck with that manual suction bulb, the adapter. Part of the reason why those things are not as effective as they could or should be is because we don't practice with them. You just take a cup and put some secretions in it and try whatever improvised suction device that you can come up with, and see how well that functions. Like, where does it stick? You know, where you know, how do you pull the plunger back? You can't do it with one hand unless it's got one of those little thumb loops, and then your hand has to be strong enough to pull it against whatever you're trying to suck through the tube. So whatever improvised suction device you have, practice it and find out when it's going to work, when you can make it work consistently, and when you can kind of go, you know what, I'm not going to be able to pull peanut butter through this tube. You know, so I think part of that is just becoming very familiar with your equipment, not just having it, but knowing how it works and when you can anticipate that it's not going to work.
And you got to practice with chunks, like pea soup. I think with peas in it, get peas and maybe some chunky soup from Campbell's. And it's not always just pure liquid that we need to suction up. And yeah, you got to practice with that.
I would say practice with something like baby food initially, and then throw some chunks in there, throw some cut carrots or peas, or, you know, without making this a Betty Crocker cook class, just start off progressing. Start off with clear liquid. Can you get clear liquid through a syringe and an IV tubing? If you can't get clear liquid, then that's a good indicator that it's not going to work when you actually have real secretions with chunks.
We have one question from Phil Clark, and he's about your mental checklist. How does this compare to the written checklists?
Well, mentally is, you should, if you're going to try to get to mastery level in any skill, whatever procedure you're learning, you should be able to mentally go through from start to finish, meaning mentally considering that you have to do the procedure, to having a mental picture of everything that you need to successfully perform that procedure. And then how do you have it laid out? Which tool do you grab next? Is that tool positioned properly on the tray that when you grab it with your hand, you immediately are able to function and implement that? Do you have to manipulate it in your hands before you apply it to the patient? So you're mentally going through that checklist without that external reference. It's all internalized. And so going from being oriented to a procedure to being proficient in a procedure to having mastery of the procedure is what that mental preparation and rehearsal can help you progress. If you don't quite have it to where you can commit every item and process and step to memory, then that's an indication that you should continue to do that mental rehearsal. If you have to have an external checklist as a reference, that's fine. That's a tool to get you to the point where you have mental mastery, where you can do this without an external reference. That's a great question, though.
Let's go to monitor.
So what do you have to monitor?
Yeah.
You've got a pulse oximeter, which was an excellent tool, right? Because it gives you a pulse, and it gives you might even give you a pleth wave, give you oxygen saturation, all of those things. Those are good bits of information that you can get when you just look at your patient. Monitoring before this without equipment is looking at your patient, seeing where they are, and having enough of a reference to see whether their trend is to get better or worse. When you look at a patient, you should be able to go, oh, that's a sick person, or they're okay, right? And then you have external data that validates your visual interpretation of what's going on. You can look at a person and they look sick as shit, and their vital signs are solid. And you're like, there's a disconnect. And you can look at somebody and they look perfectly fine and their vitals are crap. And so you're going to form that visual reference when you look at a patient, sick or not sick. And then you're going to try to decide based on the history and trends, are they stable or unstable? And which way are they trending? Those are, that's your pre-checklist before monitoring. Now, monitoring, you're going to get into tools. So what external device is going to provide data, whether that's you're going to have a pulse ox on them, you're going to have some type of capnometry. You're going to be able to, do you have a full-on monitor that you've got them wired for sound and you can see an EKG tracing, you can see all of these things going on. You got, regular monitoring of their blood pressure, which provides a map. You can escalate as the equipment allows you to do. But what's not on this list is just your eyes looking at the patient.
We have a question from Lassa. He wanted to discuss the managing of an intubated patient in a prolonged field care environment. How do you walk that line between the drugs needed to keep them down and not down so far, or how do you, I'm now extrapolating onto his concept of, how do you make your drugs last longer, and how do you deal with that really crappy situation?
That's a good question. First off, deciding to take an airway, one of the costs of doing that procedure is that you no longer get unprompted feedback from your patient, right? If they're not intubated and they're able to talk to you, that's a means for them to communicate what's going on internally. After a while, you're going to learn how much to trust what the patient says, right? If somebody, like in the ER, if somebody comes in and says, "Hey, I think I'm going to die," like, take them seriously. Like, they're there for a reason. But if it's the same mental patient that comes there all the time every week, well, then you're gonna gauge your scale based on history and stuff. But you lose that unprompted feedback from your patient if you take their airway. They're going to still tell you in other ways. If they're not fully sedated, they're going to start posturing. They're going to move. Somebody that's in pain is going to constantly be squirming around and fidgety. So all of those things are going to give you visual cues to get feedback from your patient. Yeah. Doing pulse dose sedatives versus IV sedation is one way to extend your medicines. When you're trying to decide what that dosage is, I would, there's a couple different ways. You can just look at the CPG about what is your sedation dose for that medicine, whether it's ketamine, morphine, whatever sedation drug of choice. Ketamine we'll just do as a generic one. You can do the weight-based for sedation is 1 to 2 milligrams per kilogram per hour. You can, if you've been monitoring this patient and giving them medicines for a while, you can look at their history. How much medicine have they required to control their pain? And then how close is that to the reference for the CPG for pain is 0.1 to 0.3 milligram per kilogram per hour for pain control using ketamine. Are they falling within that window with their actual drug requirements to maintain pain control? Does it match what the initial drug calculation? Because reality always gets a vote. You can say, hey, the drug says I'm going to give 0.1 to 0.3 milligrams per kilogram, but they're requiring more. Your concern is if they're using more than 0.3 milligrams per kilogram per hour, then that's defined as the party zone for ketamine because it's 0.3 and 0.1 or 0.9. That's generally an area you want to avoid. But what you might find is that you're giving them an actual amount that would calculate out to somewhere in the party zone, because every patient gets a vote. Reality gets a vote on what a patient actually needs. So you can kind of figure that out. And then that's a starting point to consider what you need to do for IV anesthesia to give them a standardized, stable dose over a period of time. You should I would say you would typically use less medicines using IV anesthesia as long as you're not moving the patient. If you have to move the patient, most of us do not carry an infuser. So you're going to have a lot of variation in your administration if you don't lock that down. So if you're stable in one location and you can transition from pulse dose pain medication to sustained IV medication for pain or sedation, then you're going to use less medicines that way. So that generally will be a way to, to do that. Sorry for the long dragged out answer, but I'm thinking through it in real time. So like doing math in public, sometimes it's embarrassing.
Nice. So mismade. Let's we've done MSM, now Airway. What are we looking for with Airway in the mismade checklist?
Well, I think this goes back to being prepared for the most likely requirements for airway management and the most dangerous, right? So most likely is you're going to have to do some type of BBM, bag assisting, for the patient that just needs a little help. You know, maybe they got fractured ribs or something, and you need to help them breathe a little bit so they don't work as hard. You know, that's a pretty likely scenario, to the point where you need to breathe for them. It means you're going to have to do some type of, surgical crike. If you're going to do that, you need to be able to provide some type of continuous sedation. You're going to monitor them. If you do provide sedation for a patient, you need to dedicate a person to monitor them that basically never leaves their bedside. You could chemically paralyze them if you're going to do some type.
And you have lots of the drugs available to keep them down. That's and PFC. That's always a challenge.
Yeah, I think at some point, like, people will know how to start a surgical airway or do rapid sequence to intubate somebody. We don't really go over the training on when to extubate somebody or when to pull a surgical crike. I mean, it is just as simple as pulling it when you terminate a surgical crike. They make a big deal about it. But I talked to a couple of trauma surgeons, and they're like, no, you just pull it out. Really? It's not some magical thing where I got to look behind the curtain to see what's the secret. No, I just pull it out. You do need to secure the airway, but you could seal over it. Maybe they oversimplified that when they explained it to me, but I was pretty shocked when I heard it. So
seems easy. Put a plaster over the hole, you should be fine.
A little spackle, yeah.
All right. Okay. Proper tube placement. What's the thinking here?
Well, you just have to. I mean, you have to make sure that if you're putting a tube in an airway, are you in the airway, and how do you confirm that? Whether you have the that colorimetric capnography that you put on the tube, so you start seeing the change color and you're in the trachea, or you just have auscultation. It still amazes me how many times people will listen and they don't listen to the stomach first. The most likely indication that you're in the wrong tube, you're in the wrong spot, is to hear gurgling in the stomach. And so you should listen there first. It's common sense, but apparently common sense isn't so common. So it's amazing how I still people, and they listen in the right or the left side, depending on which side they're standing. They tend to listen. If they're standing on the left side, they listen in the left chest first. If they're on the right side, they listen in the right chest first. So it's almost geographical, but they should be listening to the stomach first every time. And then you can listen in the right. But if you listen in the left and they've right main stemmed it, of course, you have a visual indicator. If they've hubbed the tube and they're in the lungs, they're going to be in the right main stem overwhelmingly, right? So you listen to where there's going to be a complication first, stomach, and then you listen into the left lung. If the tube is too far advanced, you should have diminished. So you'll hear low breath sounds if you hear them. And then you listen in the right, which would be the ideal location where you'd hear both. But it's also another indication that you might be right main stemming it. And so if you have diminished on the left and you hear them much louder on the right, then that'll tell you that it's in the right main stem. And then you can look at the tube for a visual confirmation that it's probably too far advanced. And then you can retract the tube a little bit until you hear equal breath sounds. So developing a kind of a systematic way to assess confirmation of tube placement should start with the stomach, then the left lung, then the right lung.
I'm happy to see that they have ultrasound in the better option. but ultrasound, you're only going to see it in the trachea. You're not going to see right or left stem.
Yeah, but
Can't
if
quite
you're
see it
not
that
if
far
you're not
down.
trained in what that looks like, it still can be confusing. You could falsely say that you're in the right spot. That's I mean, I'm a huge fan of ultrasound. But it's one of those where I think there's much better ways to confirm. I think the capnometer is phenomenal. Like that makes it idiot proof. I mean, we design better idiots all the time, but I think that makes it really hard to think you're in the wrong spot.
Yeah,
But I
and
think
it's right there on the NPA anyway. So you've done that as you go through your airway ladder. You have the NPA and the ETCO2 is right there. Then you intubate. You can easily. It's right there, and why not? It's golden rule.
Yep.
Good.
No, that works really well. But honestly, this is where the basics. You don't need much more than the basics. If you have a stethoscope, listen to the stomach, listen to the left lung, listen to the right lung, and I think you'll be fine.
All right. The last one in Mismade is drugs. So what are we looking for here?
If you have the time, if you're doing a surgical crike, generally you're not going to have enough time to do local anesthetic. If you're doing like an emergent versus an urgent. If it's emergent, you're going to just cut through the skin. You're going to do it fast. You need to have suction to get the blood out of the way. You could even elevate the head of the bed just a little bit so that any blood flows. It doesn't pool right there where you're trying to cut. It kind of comes down a little bit. You know, that's kind of a pro technique too that I've seen. But if you have an urgent airway, then you might have time to do local anesthetic where you're going to make the incision. That's the thing. If you can, just put a little bit of lidocaine there. If you have the ability to squirt a little bit of lidocaine into, like through the cricothyroid membrane into the air, that'll help prevent a little bit of spasms. But most of the time, you can just cut right through there. If you have a chance to, add some ketamine or some opioids to reduce some agitation of your patient, because they're going to be fighting you. In training, it's always funny where they're doing the surgical crike on somebody and they're fighting, and then when the blade gets close to the prosthetic that's sitting over their neck, they just like freeze. That's not realistic. I think if anything, I'm going to increase my resistance because you're coming at my throat with a knife. But once again, I'm worried about breathing. So, and then of course, if
Speaking of lidocaine, would you squirt the vocal cords if you were doing a intubation?
I've done the spray before. That kind of helps a little bit in the posterior pharynx, but it really depends on how much time. Is it an emergent rapid sequence intubation, or is a planned urgent procedure that I've had time to prepare and do everything that I need to do? Like I know I'm going to do it. I have all my medicines. I pre-oxygenated. I've done all of the things before I get to step 7, where I actually have a laryngoscope in my hand. What do I do? If I have the time, I'm going to take the time to prep and do all the cool stuff that helps.
And then the best is ketamine.
Yeah, if you can do the dose. And like the comment up here says, most sedating agents can be given IM if you haven't done an IV or an IO. IOs are so easy to put in based on location and stuff. You should be able to train your non-medics. I'm speaking from a soft history background. We train our non-medics to do these things. So it's, they augment the medic, and they're assets for the medic, not liabilities. So you want to train your non-medical personnel to help whenever possible.
So IOs are definitely almost idiot proof, but if you don't have them, the IM ketamine in the shoulder is really, really beneficial, just to give you an edge as you work. So you put that in immediately, and then you get your kit ready to go. By the time you're ready to do a surgical airway, the 120 seconds are up, and hopefully some of that ketamine's on board. So prolonged sedation. But we've kind of hit this already. We've got some good questions, but minimum, better, best. Like S-ketamine. Do you have S-ketamine over there?
Not as much. I mean, we've trained on it, so it's more concentrated than regular ketamine. It's interesting that the European medics, military medics, use the same TC3 dose of S-ketamine that we use for ketamine, even though it's a stronger medicine. So,
Wow.
mm.
Wow.
But once again, I think a lot of our patients can tolerate a little bit more than the 0.3 milligrams per kilogram of the ketamine, as evinced by the S-ketamine using the same dosage range. So it's like, I think if you add up the normal TC3 doses that you give before you get an IV or IO and after, when you're trying to maintain that initial trauma pain, you're overcoming the most pain that patient is going to have with those initial doses, right? So then by the time you get pain under control, so they're therapeutically controlling their pain, you can give considerably lower doses because you're not overcoming that pain. It's the same reason why you have a PEEP on the end of your BVM. Once you overcome that initial resistance of the alveoli opening, the effort to put air through the airway is less because the PEEP is holding the alveoli open and you're correctly positioning your patient. So you're not having to overcome those obstacles from air that's outside the mouth to air that's inside the alveoli. That's the smoothest, least resistant path based on positioning in the PEEP valve use and proper seal. Like, all those things make the airway easier. I think we talked about positioning of maintaining a good seal using the E to hold the jawline in position and the C to maintain a good seal with the mask on the face. We didn't talk about hand position. So, and it's not mentioned in the CPG. You should be holding the bag with your palm up. The bag should sit in your hand, and you should use your middle and ring finger and your thumb to just bring those two together. If you're doing that with a normal, 1,000 cc bag, adult bag, you're going to give somewhere between 400 to 600 cc's of air each time you squeeze. Now it's worth taking that process and looking at it and maintain it. And your pinky and your index finger are basically stabilizing the bag in your hand, right? You're not gorilla gripping the thing and squeezing it like it owes you money. You're just squeezing it every 5 to 6 seconds, giving 400 to 600 cc's each breath, and then that is adjusted based on the saturation of your patient and their end tidal CO2. Like, this is a kind of a dance that you're doing for that prolonged bagging of a person. The complications of putting your hand on top is if your hand's not big enough, or it's slippery with saliva, blood, and fluids. You end up pushing down, and what that does is that breaks the 90-degree seal, over to the BVM and the angle devices and all those things that you have from the BVM to the patient's face, and anything that's going to cause that angulation and force, that's going to break the seal. And when you break the seal, then your PEEP is useless. So you have to get the seal first, get that first couple breaths in there to open it up and maintain a seal so the PEEP is effective. So I don't think we hear it enough in training that when you're holding the BVM, your palm should be up and the bag should sit in your hand. That's gonna help maintain that seal, just as a good technique. Instinctively, I see people just too often grabbing the top of the bag and they're fighting themselves. If they break the seal,
it's just a matter of it's muscle effort as well. It takes more muscle to keep it up like on top. And I'm a lazy medic. Why not? And if I'm going to be doing this for 8 hours, there's no way I'm going to do muscle failure. So yeah, hold it underneath.
Yeah, you're not going to be able to do it for 10 minutes. You almost watch when they fatigue, they'll instinctively put their hand underneath, and then they'll bring their knee up and they'll rest their hand on their knees. Like, they'll do all these things. They've already worn themselves out. So start off in the lazy position. You can just, start off slow and taper from there.
Yeah, good. So on the best, can you talk about the hydromorphone? Why would that be an alternative opioid?
It's longer acting.
Right.
I think when you're giving, this kind of goes into pain management. That's further down in the march. But if I'm giving you 20 to 25 milligrams of ketamine IV every 30 to 45 minutes, based on how long and how severe your pain is, at some point for me to stretch out my medicines, I'm going to drop that dose. I'm not going to tell the patient I'm only going to give them 10 or 15 milligrams, right? But I'm going to have the calculation in my syringe that every cc is the dose that I want to give. That's just easy math. So if I want to give 20 milligrams of ketamine every time I give a cc, that's the concentration that I'm going to calculate to put in my syringe, right? So if I have a 10 cc syringe, I put 200 milligrams in the syringe, and then I fill the rest with saline, and now I have a 20 milligram per cc dose in my syringe. So if I give them 1 cc every time I give them a dose, and I document that, I can see, hey, my 20 milligrams is lasting X amount of minutes, 45 minutes, or maybe 50 minutes, or an hour, or if it's only 30 minutes, I can gauge that. And then at some point I can say, you know what, I'm going to give you another, you look uncomfortable, let me give you some more medicine. I can just give them 10 milligrams or half a cc. I'm not telling them I'm giving them a lower dose. I'm just telling them I'm going to give something to help make them more comfortable. And then I can see if 10 milligrams works. If it doesn't last as long as my 20, then I can really start trusting the level of pain that my patient's in. I mean, of course, they're getting the benefit of the doubt. I don't want them to be in pain, but you should also set the right expectation and let them know, I'm not going to take away all your pain. I can't, because if I do that, it means you're going to sleep, and I need you awake to tell me what's going on. Right. And so I'm going to get your pain level to where you're not uncomfortable, you're not being tortured, but I can't make it go all the way, because then you're not going to talk to me. I need you to talk to me. And so you build that rapport with the patient, you set expectations, and you're going to have better success controlling their pain, because you're being upfront with them, and you're setting the expectations at the appropriate level. Like, you're going to have some discomfort, but you're not going to be in pain. You're not going to be uncomfortable, put it that way. I'm going to make you a little more comfortable, but you're not going to be easy chair kind of thing. So I think being upfront with your patient and clarifying that goes a long way towards managing overall pain for a prolonged situation too.
Yeah. Can we talk about improvisation a bit?
Of course.
So there's a lot of stories out there. There's even publications on PubMed on the use of improvised surgical airways, and most of them are bollocks. And you're not going to want to use anything for a surgical airway that you can't personally breathe out of yourself. So when I teach this, and at SOMA, we're going to have an improvised medicine workshop, you can just give someone a 6 mil Crike kit, have them put it in their mouth, see how long they can breathe. They're just not going to do well. And it's the same for, what's the next slide? I have, the biro, the pen. So everyone says, oh yeah, no, I'm going to be able to use a straw or a pen. And I would encourage any of them to try breathing through whatever device that they're going to be using, and watch them and laugh as they go unconscious, because they don't have the ability to ventilate.
I don't think they'll have the discipline to keep breathing until they go unconscious. They'll stop long before that. No, I think if you have an oxygen concentrator, you can extend the amount of time a patient will tolerate a really small airway. But I think if you just take a 6.5 ET tube and just sit in a chair and see how long you can comfortably breathe, like, you might be able to get away with it for a little while. But then if you even, like you said before, pre-conversation, that you put a pulse ox on somebody and you watch their sats drop over time, and what you're going to see probably before then is the work of breathing. They're going to work harder to breathe through a smaller airway, and that is just going to fatigue them. So that's going to drive up their energy expenditure. So then all of these things have consequential effects. Like, you could put an airway in, but if you don't have the ability to supplement their oxygen, to make it more effective, whatever is getting in there should be more effective. It's actually carrying a greater concentration of oxygen. That'll help too. But it's a Band-Aid for a situation. If the airway's too small, looking at the pen, everyone thinks the middle of the pen is what they're breathing through. But if you look down where the silver end is, that's what they're actually breathing through. So it's not a realistic, like, there's no way you're going to sit there and breathe through that. It's not for any length of time. So, and one thing I point out too, don't cut the ET tubes. These are horrible. These are accurate representation, but they're horrible in that if you're going to cut these tubes, you don't cut the tube, you take the cap off the end and then cut down the tube and leave the end of the regular tube intact, because those are too sharp. Those are going to perforate, you know, the airway when you try to stick them in. They're not rounded, they're not blunt. Those are going to cause more complications. So if you do have to cut a tube, you're going to cut the tube at the top, you know, and then put the cap back in it if you have to do it. So, and they're not going to be cuffed unless you separate the connecting tube that goes from the plunger end to where the bag is. So all of those things are going to be components to doing this. But yeah, these two are perfect examples of what not to do.
Yep. Good. So that winds up our CPG for Airway. Again, I apologize for the new format, that we had to be a bit more strict on letting people in. Next month, we will have the messaging sorted, so you guys will be able to have messaging in on questions. But thanks for joining us for the A of March, and the first Saturday of next month is SOMA. So we're probably going to have to do it a little later in the month. We'll let you know when that is, when we will do our respiratory.
Thanks, everyone.
Yeah, thanks for coming, guys.